Good morning, everyone. Welcome to the Young Ophthalmologists in International Ophthalmology session. This is another SOE YO Young Ophthalmologist session. Thanks for making it to the final morning and getting up early to join us. I think we've got a really interesting program for those of you who are internationally minded or interested in the more esoteric ideas of education. So let's get started. Our first speaker is Wagi Aklamendos from the United Kingdom, and he'll be speaking to us about the European Board of Ophthalmology, exams, logbooks and residency exchange.
Good morning. Thank you very much. Thank you very much, Anthony, for the invitation. It's a pleasure to be here. I apologize for those who have listened to a very similar talk in the last couple of days. The EBO has not changed much in the last 48 hours, so what I have to say is pretty similar. I will... How long do I have?
About 10 minutes.
Well, the question was, what does the EBO do really, and how can it help in the education? And it is involved in the training of the young and the not so young ophthalmologists. There are 4 parts to our training. We all go through the undergraduate training, postgraduate training, we go through the subspecialization for many, and then it's an increasingly important area, which is the maintaining the professional standards and the high standards of practice. And the EBO is to some extent involved in the latter 3. Just to clarify the acronyms, the UEMS, if it's not entirely clear for some, is the Union Européenne. I couldn't get the accent on this one, but c'est l'Union Européenne de Médecins Spécialistes, which is more the political wing, and it meets with all the other specialities twice a year, once in Brussels around February, March, and once later in the year in a different place every time. And the discussions are mainly around the political parts, like mobility, European Working Time Directives, and it is a very important but painfully slow kind of organism where we talk about the difference between aesthetics, plastics and cosmetics, and a discussion like that can go on for an hour and a half. With translations, so you can imagine it can be painful. On the other hand, I've always argued that if you're not prepared to be in the kitchen, you can't complain about what comes out of it. So we need to be there, because otherwise we get things like European Working Time Directives imposed on us, and they apply to doctors as well as plumbers, as well as any other profession, let alone different specialities within medicine. So we need to have a presence, and the section of ophthalmology is led by Costantino Bianchi. He's currently the president of the UEMS ophthalmology section. The EBO is the educational wing, and it has 4 committees. The educational committee is mainly, its main activity is the exam, the European Board of Ophthalmology diploma. I'll say a few more words about it in a moment, because that's the main reason I'm here. And the other committees are the Residency Review Committee, which inspects units and gives a sort of certification of excellence in training. So there is an application form on the site. Again, I'll just say a quick word about a couple of those. Sure, it's gone back. And the Residency Review Committee, Exchange Committee gives grants, and the CME Committee, it's pretty obvious what it does. Now, the Education Committee, as I said, does the exam. To be allowed to sit the exam, the people have to be either in the last year or have done at least 4 years of training in a recognized European training system. Then they do the exam. Then, if they haven't actually completed the training at that point, they get a certificate. And only when they have completed the training, they contact their national delegate, who confirms to the EBO that that is the case. A completed training plus having passed the exam gives them the diploma and hence the right to use the post-nominals fellow of the European Board of Ophthalmology. Now, in an ideal world, you would like to be able to control that training as well as the exam, but we have to live in the real world, and whilst we would like through advice, guidelines, and hopefully exchanges in time to reach a uniform training, this is a very slow process if we'll ever get there. So we have to compromise and settle for whatever is a recognized training in a European country plus the exam. The exam is held once a year in Paris. It consists of MCQs in the morning and 4 oral examinations in the afternoon. And I just explained the difference between the certificates and the diploma. The Residency Review Committee is a bit like, for those who are familiar with the British system, used to be college inspections. It's not, the word inspection may have the wrong connotation. It's not meant to go and tell people off. In actual fact, many units use such inspections to get help. And we have been to units who have said, you know, it would be good if you put in your report something about the need for more IT support, etc. So it's not meant to be a confrontational thing. Actually, it's an entirely voluntary thing. The application form and the whole process are described on the website, so I won't bore you, but it's a rather thick application form which has all the description of the department, all the available specialities, the staffing, the timetable of the trainees, etc. Then a small committee which involves the national delegate of the country in question and an external person go and visit the department, meet with the chiefs, meet with the trainees, have discussions, and eventually issue this certificate of training, which says that this center is recognized as a training center. And I will mention something about the grants in a minute, and people who get grants can go to units which are recognized for training by the EBO. The third committee is the Residency Exchange Committee, which is the one that gives those grants. And we give 40 grants a year. There are grants for trainees and there are grants for trainers. It's not an earth-shattering amount of money for each, but it allows them to go and spend a month, or some trainers choose to spend less time, like 2 weeks, in a different department, learning a bit more about the system in the other department. And I must say, I didn't do it with a grant, but with the role I've had in the Residency Review Committee, I found visiting other departments sometimes extremely helpful. The CME Committee works very closely with IACME and is a victim of its own success, really, because now CME points are applied for by meetings from all over the world, from China to Africa, so it's not just for the Europeans. Now, why is this necessary? Because the world around us is changing. Europe is certainly changing very much. And I said in my talk a couple of days ago, so I'll go very quickly through that. But Europe has strong points and at the same time big challenges. Put together, the European countries are twice the United States in population, and yet each country has a great history and a great culture, but this is a plus and a minus, because each country has its own process, and different processes can be good or equally good, or have produced great ophthalmologists. There is no doubt about that. So each country has a contribution to make. We differ. Each country by itself is changing, let alone the whole combination of the relationship between European countries. We have to look at the things that we have in common and how we use that to move forward. It is obvious that language will always be a challenge across Europe, although we are all here speaking English, and it is a fact of life, and we can discuss that. The EBO is held in 3 different languages, French, English, and German, but if we're going to go down subspeciality exams, there is an increasing pressure to stick to English. At the same time, to be fair, I can perfectly see the point in going the other way, and having had a lot more Spanish candidates this year, there was quite a bit of noise being made about why don't we add Spanish as a fourth language to the MCQs. So that's one of our main challenges. And the fact that people who are in have different training systems, different cultures, etc., cannot change overnight their systems. In France, ophthalmologists are not opticians are not allowed to prescribe glasses up to the age of 16, which means that every 10-year-old short-sighted has to go to an ophthalmologist. And in the UK, we have the opposite, with now optometrists getting involved in virtually every part of our practice. So those changes have to do with the tradition, but also have to do with the expectation of the patients and with the number of ophthalmologists, which varies enormously. Now, this is changing. We are all going to be allowed to work, or are allowed to work now in different countries. Once you are a registered specialist in a European country, you are entitled to apply for the job in another European country. Whether you get the job or not, of course, is a different story. But theoretically, we could cross the borders and work once you have become a specialist. And it is one of the main challenges for the UEMS now to look into equivalence of qualification, because clearly 3 years of training cannot be equivalent to 8 years of training. But this means that people are traveling across, and there is an obvious move from low GDP areas to higher GDP areas. And this is going to narrow those financial gaps. There is obviously, and we see that with the UBO, the need to continue to train equally and to maintain the same standards. Once you're a specialist, those expectations are the same. So we have to look at what we have in common. We all have the same aspiration, which is to have very high standards, and we tend to reuse the same textbooks. Now we have the EBO holding an exam, which is the same for everybody. We should make sure we don't make the same mistakes as the past. We have to take the positives and have a plan of action and make sure that everybody's involved, everybody has a say, rather than anyone appearing to be dictating to the others. We should try and avoid the hurdles which are pushing people off the system altogether at times, and look at the successful systems. And the UK has been successful because it had a large number of people speaking the same language. It had high standards in the exams and maintained them, and hence acquired the brand. So this is what we have to learn. United, we're stronger. Set has high standards and be very consistent, and then the brand will follow. So hopefully the EBO will be able to help more with the postgraduate education and the subspecialization part by now having committees that are looking at this subspecialization and is considering holding exams in the subspecialization, so that when people sit for the EBO exam in Paris, they might also be able to go for an exam that is a subspeciality exam, and hopefully this will start in 2015. Thank you.
Are there any questions? If I could start, I think the EBO are doing a fantastic job trying to harmonise education across Europe. It seems to be largely clinical. Does the EBO have a role in harmonising surgical training and standards?
This is the main challenge in training, because we go back to the point I made more than once, which is the difference in cultures. Now, there is nothing wrong with the Swiss system, where people learn ophthalmology in 4 years, and then those who are going to become surgeons learn surgery in another 2 years. And whilst in an ideal world you would want everybody to do the same, if a country is producing 4 times the number of ophthalmologists compared to the number of ophthalmic surgeons they need, it is very difficult to impose on such a country the need to force everybody to train in surgery. It doesn't make sense. It's actually a waste of surgical training opportunities. So I think, as you know, I skipped the survey. We found huge differences from doing no surgery at all to, in the UK, 50 cataracts a year being the minimum compulsory. And yet, it's very difficult because in the UK we have a third of the number of ophthalmologists compared to France. So how do you force someone to train more? I guess in time these variations may balance out by more ophthalmologists migrating from areas where there is a surplus of ophthalmologists to areas where there are fewer ophthalmologists. So in time it might balance up. But I really would love a system where you can impose this, but in practical terms I don't know how you can put sort of all the history and the current systems behind and start from fresh in a completely different system and impose it.
Yes. So I actually just have a couple questions. So as an American, we clearly have, issues. Well, one, I can't migrate anywhere, so which is interesting. I find it fascinating that a lot of my friends in Asia, who are trained in the UK, can go back to Hong Kong and so forth. I can't really go anywhere without being at a university post. So it sounds like you're trying to standardize where people can travel from one country to the other. But going back to the surgical question, do you have a minimum surgical requirement? And I also, my other question is, we deal with the AUPO thing in the United States, and that is not a government body. And my question also is, what's the incentive of a program to actually be EBO accredited?
Well, the first question was about the right to work. This is actually not ophthalmologist or EBO who decides that. It's the politicians who have decided that. So it doesn't apply just to ophthalmologists, just to medicine. If you are a European citizen, you are entitled to apply for jobs in other European countries.
Right.
The frontiers have gone down, theoretically, which means that you're entitled to apply for the job. Now, there are language barriers, which mean that fewer people are going to go to Finland, where the language is nearly impossible to learn, and you have to speak Finnish or Swedish to be allowed to work there. And there will be a lot more people migrating towards the UK because English is spoken more by the others. These are the facts of life that, unfortunately, politicians almost feel that it is politically incorrect to talk about.
Right.
The answer to the minimum surgery, I think it is, as I said, very difficult to impose that if people have a system that's working. And we can make recommendations. There is recommendations made about the minimum length of training, which the UEMS said should be a minimum of 4 years. And yet there are 2 countries that still have 3 years. So it's sort of just starting to tackle that. But actually to impose an actual system of training is very difficult, if not impossible at this point, in my opinion.
Thank you, Wagi.
The answer,
I think we'd better move on, and maybe some of these issues will be described by our next speaker, Ivan Haflinger from Switzerland. We'll be talking about the European Union of Medical Specialists, what happens after we become licensed, the difficulties.
So where do I get my presentation? So I will address some of the issue of the European Union of Medical Specialists, the UEMS, and issues and challenges once being a specialist. So once you become a specialist at your national level, there is an association that represents you in order to defend and promote your interests. So this is schematized like this. You have a society, it's National Society of Ophthalmology, but you have the same system with other specialties. And this is regrouped at the national level into a national medical association. And you have the same organization in 34 countries, European countries, so it's more than the European Union because it includes also Iceland, Norway, Switzerland, and some other countries. And they are regrouped in the European Union of Medical Specialists, the UEMS. And the UEMS is divided again in sections for the different specialties. So you have the section of ophthalmology, but you have 39 other specialized sections. And from these sections that deal with the politics, but are also responsible for the education, there is a subsection that are the European boards and what we know, the European Board of Ophthalmology. So you, as an ophthalmologist, you are dealing with your National Society of Ophthalmology, and then they are interacting with the UEMS section of ophthalmology and the European Board of Ophthalmology. So the UEMS is a union, it's a kind of syndicate that represents the National Association of Specialists of 34 European countries, and it's quite a large number of specialists. It's 1,600,000 specialists. It's really big. And within the UEMS, the different medical specialties are represented by section. Our section is a section of ophthalmology, and it accounts for 40,000 ophthalmologists. So the UEMS section of ophthalmology is representing 40,000 ophthalmologists within Europe. And this is schematized like this. So once you become a specialist, your title that reflects a minimal level of education and training that has been achieved is recognized within countries of the European Union, as well as Iceland, Norway, and Switzerland. It means that someone that is graduated or finished his specialization in Romania can easily go to England, to Switzerland, and vice versa. Someone from the Netherlands can, in theory, or has his diploma recognized in Italy. So to this regard, one can say that there has been a real achievement in unification and harmonization within Europe. So although national titles of specialists are mutually recognized, the healthcare politics and their organization are still very heterogeneous within European countries. Why such heterogeneity persists? One has to realize that in the European way of thinking, health rates at the top priority. And for some single individuals, seeks for health seems sometimes unlimited. In other parts of the world, it's food, water, that is the most important priority. But in our system, it is health, because we have enough, or we are developed countries. And this accounts for, within Europe, a mean 8.3% of the GDP. It varies from 5.5 to 11.2% in France, in Germany, Switzerland. It's also above 10%. So in such a context, it is really an important part, or the costs are really very high. And in such a context, European governments are committed to ensure and finance healthcare access to everyone through subventions. So as a significant percentage of the national GPS are devoted to healthcare, and as government have to subvention it, they need and want to regulate it. That's normal. So to cope with these issues, national European governments are adopting different and single individual strategies. They are often in part influenced by political conjunctures. And changing something in these organizations can have huge consequences, not only on the health costs, but also a lot of people are working indirectly with health. For example, in Switzerland, they changed the tariffication, so everyone was very careful. You had no more investment made. So the people in the commercial exhibition were complaining, we cannot sell anything for 2 or 3 years. Then they don't buy cars. So really, it's very, very large. If it's 10% of the GDP, it's not only health, it's very large, and that's why it's very sensitive and difficult to regulate. So to come back to our field, among many other strategies to decrease health costs, beside controlling the pricing, partial reimbursement for patients, One of them is to regulate the attribution of the number of licenses for specialists to practice independently, because in many countries, if you are specialized in ophthalmology, it doesn't mean that you are allowed to practice. You need permission for that in order to control, actually, the number of specialists. So in a system that tends to limit the physician's resources to a minimum, because they want to control cost, limiting the number of licenses to practice is a very efficient way to limit costs. So from the point of view of newly specialized physicians, young ophthalmologists, this type of limitation can be a real problem, but not only for them, also for the entire healthcare system. Indeed, in contrast to some other part of the world, Europe has a large and fast-growing aging population. In other parts of the world, it's the contrary. It's the youngest population that is the largest one. So in this context, keeping constant or even decreasing the number of licenses attributed to practice when physicians are specialists, or decreasing, so if they cannot go into practice, they stay in the training system longer. So they decrease indirectly the number of specialists in training once they became physicians, and also decreasing the number of medical students that are trained to become physicians with numerous clauses, leads to a shortage of human healthcare resources, a shortage that is already occurring in European countries. And this leads automatically to a phenomenon called human capital flight, brain drain, that usually occurs from countries with a lower to countries with a higher GDP. When we are sitting in the UEMS section of ophthalmology, the Bulgarian complain that as soon as their residents are specialized, they tend to go in another European country because they earn much more. We cannot blame them. But it depletes the Bulgarian from the investment that they have made. And in Switzerland, we have a lot of people coming from Germany, so they are replaced. And from countries where the GDP is lower, then they tend to take specialists from other countries, from Northern Africa, for example. So, taking this in account, one has also to realize that the domain of medicine, and in particular ophthalmology, are being all the time challenged. For ophthalmology, if everyone still agrees that vitreoretinal surgery belongs to the domain of expertise of ophthalmologists, other fields of ophthalmology that were traditionally managed by ophthalmologists are challenged. For example, lid, lacrimal, orbital surgery often tends to also be performed nowadays by other surgical specialists, such as dermatologists, ENT, plastic surgeons. This is just for one subspecialty of ophthalmology. But cataract surgery in some part of the world is already performed by non-physicians. Within Europe, conservative ophthalmology is done by non-physicians. And the worst probably for us is technology, because it replaces human resources or medical treatment that makes some disease disappear. So such trends, reflecting unavoidable evolution in ophthalmology practice, but also in medicines in general, have to be acknowledged and anticipated in order to adapt the training of new coming generations of ophthalmologists. So, in conclusion, for the best of our patients and to cope with ongoing changes, European ophthalmologists have to be unified to be able to speak with one voice, because if we are many, it's very difficult. The UEMS section of ophthalmology and the EBO are structures that exist, but to become stronger, they need new strengths. And these new strengths have to include and have to come from young ophthalmologists. It is better that we take our destiny in hand to initiate ourselves necessary changes if we do not want to have them imposed by non-ophthalmologists. And to this regard, because young ophthalmologists are probably the most concerned by these changes, they need to be, and we have to let them be, proactive. And this, of course, for the best of our patients. Thank you very much for your attention.
Any questions? Can I just ask, in this regard, other than forums like this, what are the UEMS doing to engage young ophthalmologists?
Not a lot yet. That's obvious. But if there were some, I think we have to include them. And what I would like to say that it has to be, usually in the UEMS it's rather older generation, so they don't see and they don't feel the changes as much as young ophthalmologists. But I think we are open to let them come and to hear their ideas and that they help us to make these changes.
What are you exactly doing to advocate right now? So
That's-
right. I mean, this is you talk about the brain drain, and
Yes.
you're sort of limiting ophthalmologists into a system where they can't practice independently.
Yes.
So that's very depressing to me.
It is.
So, I guess as an association, I mean, are you going to national societies and lobbying and trying to advocate for this change?
Well, we try, but very weakly now.
Right.
We need resources. So we need more people that are interested in this kind of issue and are ready to devote their time, because we are not professionals.
So are young ophthalmologists, are they members of this society? Or
No, but we could create some subgroups where we have think tanks and they
Right.
could participate. This is no problem.
That certainly sounds like a way forward. Thanks, Ivan.
You're welcome.
So our next speaker is Simon Keatley from Basingstoke, who's going to be talking about the ICO, the International Council for Ophthalmology, and opportunities for young ophthalmologists, examinations and fellowships. Thanks for escape.
Thank you. Okay, thanks. Great. Well, it's very nice to be here, and thank you very much indeed for giving me the opportunity to speak about the ICO to the young ophthalmologists. It's you are the seed corn of the future. We need to tell you about what things are going on in the world, and I'm going to go from Europe to international, and really tell you a little bit about fellowships and examinations that are available to you out there. We've only got 10 minutes, so I've got to be a bit punchy, so I apologise. I do have leaflets at the front, and if you are interested, and I haven't been able to go in through all the details, there's some leaflets here you might be you're more than welcome to pick up and study. Quick word about the ICO. It's quite an old organisation. It's 150 odd years old. It's a non-profit organisation based in Switzerland, and it has the World Alliance for Sight is its buzzword really. So it's responsible for education and eye care delivery around the world, and it can represent the international standard of education for ophthalmology, which sounds frightfully grand, but I think it does do a very good job. I'm going to talk about two things it does, and that's fellowships and examinations, both of which are really very popular, and people who are coming to the stand over the last few days were really very keen on both of these items. A quick word on fellowships. My responsibility is examinations, so forgive me if I'm slightly inaccurate. There is a meeting following this, which will go into the fellowships a little bit more detail, so if you're interested, do stay. There are around about 50. In fact, last year there were 90 fellowships that were offered and taken up across the world. They are very competitive, they're worldwide, and they last about 3 months. There are other ones on the left-hand side, which, my laser works, which are slightly longer, but do have slightly different and slightly more complicated eligibility. The information is from the ICO website. The 91 fellows a couple of years ago came from all those countries, so quite a lot, as you can see, from the Indian subcontinent, and quite a but there are people in Europe that do go on these things, and that's where they come from, and they go to mainly Europe, mainly North America. But it's usually an observership. There's not much surgical opportunities, but it is an observership, and I think is much valued by the people that go. There are eligibilities. You have to be under 40, which is good for you guys. You've had to already undertaken a basic residency training in ophthalmology, and you must go back to your native country after the fellowship. And if you pass the exams, you do get extra points, which allows you to be slightly more favoured for these fellowships. So another good reason for taking the ICO exams. And there are these guys looking quite happy in the snows of Germany. Right, which leads me on to the ICO examinations. The standard examination has been going since 1994. It's been sat in 70 countries, 130 centres around the world. And as you can see, a lot of people actually take it. In fact, more than one examination is taken by one candidate. It's international, and the cost, and everybody's interested in the cost, depends on the gross national income per capita. So in other words, with poor countries, you will have a cheaper cost than if you were in France or Switzerland. There are 3 exams now. The standard examination was the basic one that's been going for 20-odd years. The advanced examination is now about 2 years old, and as from last week, we've just launched the foundation assessment, and I'll go through those in turn. I'm going to talk. The exams are set by a committee which is international. The UK tends to be the sort of dominant country, really, out of historical reasons. But we do have question writers for really all around the world, and the questions that we get are really quite interesting and are relevant, I think, to the international status of the exam. It's the basic science part of the standard exam is done in Chinese, English, French, Portuguese, and Spanish, and English for all the others. It is very difficult to get translations, especially in Mandarin Chinese, which accurately depicts what we want to say in English. But we do have some very good interpreters who are able to do that. And they're the 130 examination centres around the world which help us. So each has its coordinator, and the candidates can sit in those countries. Standard examination, this is the one that's been going for some time. It's really divided up into the basic sciences, optics and refraction, and clinical sciences. The basic science exam is 80 questions in 2 hours, pretty heavy-duty stuff. And the optics and refraction is 30 questions in an hour, and both can be taken together if you're feeling completely masochistic, or you can actually separate them. It's a multiple true-false questions with 5 true-false options and no negative marking. Clinical sciences, again, is another marathon of 4 hours of 200 questions, and you need to have passed the previous basic science before you take it. And that's the elements of the syllabus, which is actually allied to the curriculum, which is published by the ICO. Give you a little bit of test at this time in the morning, which of the following statements about proven treatments for hyphemia is correct. I won't insult your intelligence, but this is a single best answer question. So basically, you've got to think which is the best of all of those that actually is the correct answer. So some of them could all be right, but some of them are more right than others. I won't query the actual facts. And I certainly won't show you too many more questions, because writing the questions is actually quite difficult, and I don't want to give away all the secrets. The advanced examination, this is a newer exam. It's been going for the last 2 years. It requires a very high standard of current knowledge, and I have to say I would fail it if I took it. It includes international medical ethics. It lasts 3 hours. with 85 questions, 10 of which are extended matching, and I'll show you a sample of that in a minute, and 75 true-false questions. And the revolutionary thing about this exam, which is different to exams across the world, is that it has confidence levels. And I'll just show you how that works in a second. That's the syllabus with quite a lot of involved questions and quite a lot of stuff. And I'll just show you a extended matching question. There's 10 of these. This is one on trigeminal neuralgia. And trigeminal neuralgia is pretty common in the UK and in the Western world, but it's not particularly common in other parts of the world. And some people do find this really quite challenging. And basically what you've got to do, you've got to read it, and that takes quite a lot of time, and it has missing words. And you've got to pick up the missing words or the appropriate words to make the sentence accurate. So if you're looking at that, and you know that, of course. So that's female, 62-year-old female, previously good health, presents with a 3-year history of severe pain in the middle part of the right side of the patient's face. How many times a day? About that, agreed. Pain's prolonged electric shock lasting seconds, probably about right. Making the patient groan out loud, grimace, clench the face. We all have to put these different words in for the international candidate. It's very difficult trying to sort of do colloquial English. And we have to read these questions really quite thoroughly to work out exactly what people would understand. Triggered by a what on the side of the face? Yeah, light touch. Fair enough? It makes you think. It's a good type of question. And I won't go on to the, this is the basic stuff. I haven't got a clue about this, but I'll tell you the answers. But there you go. But you can see they're pretty tough. They're pretty tough. Now, the confidence indicators, this is a new concept that we've got. Now, as concerning this question, the A is true, B is false, C is false, and D is true. And this is an optical character recognition mark sheet that the candidate has to mark in a pencil. So that's the right answers. Now, if the candidate says that is true, and it is, that's great. Let's assume that he misses, he doesn't know what B is, he or she, forgive me. C he feels is false, which is also correct. And D he marks as false, but as actually true. Now, that's the original way we do multiple choice questions, isn't it? But now we've got, on this side of the mark sheet, there are the confidence indicators. Now, if this gentleman thinks that he is absolutely correct, and he's really confident that he's correct, then he will get a score of +3. He'll get nothing for B, but if he feels that he's slightly less sure about the answer to C, then he'll get 2 points. But if he's really sure about something that is totally hopelessly false, he'll get -3. So we do a bit of negative marking. So basically he gets 3 points for A, he gets nothing for B, he gets 2 for C, and he gets -3 for D. So in other words, he gets a total of +2. And this is for 85 questions in the advanced exam. If you're good, you'll get your FICO. You've all had your FIBOs, but you can get your FICOs, but only really if you have passed a local face-to-face examination with, or have a license to practice from the country in which you are at. You can't take the exam and actually stick your initials after your name, but you've got to have some official thing from your country of origin. Now, the one I really want to talk about, how are we doing for time? Are we all right?
Yeah, getting near the end.
Yeah, okay. The foundation assessment is really a new exam. It started a couple of weeks ago, and it's really quite exciting. It's really for the first year of training. It's online. It's an open access. In other words, you can actually use your books and you can use your Googles or your Wikipedias to actually answer the questions. There's no monitoring and there's no security, and you can just dial it up on the website and you can get instant results. 84 questions, lots of pictures, lots of videos, and confidence indicators in the way we outlined just now. There's 6 groups, 14 questions a group, and you have 20 minutes per question, and you therefore got 28 hours to do it. And you can spread that 28 hours over about a year, as long as you want. So it's purely for your own interest and to actually see how good you are. There's the sort of question, basic stuff. And again, I won't insult you because I've got the true false answers. One piece of intraocular lens, nice picture, bit of decentration, a bit of regrowth of lens fibers. So you can actually do that quite easily. And that's what it looks like when you dial it up on the website. It's a very good, nicely interactive site. And it gives you a time limit. You've got this ticking away as you do it. And that's the sort of answer. This is, as you can see, breaking bad news. So it's all sort of relevant stuff, ticking the boxes, ticking the windows, and the confidence indicators. Was that me? Okay. And you go on and on. Thank you. Your answers are checked in, and it works remarkably well. We haven't got a try as you before you buy yet, but we're working on that, and hopefully we'll be able to introduce that shortly. You get an A star to a D, and you get an F -- if you do fail. And of course, the great advantage of this is that the local trainers in your country can define what they define as success. So if they want everybody to get an A star for their trainees, then that would be a really that they can define it as they wish. Everybody wants to know pass rates. That's what it is at the moment. I hope it'll be pretty. This one will be pretty easy to pass, but we don't know yet. But the rest of them, it's pretty tough. And that's really why you should take exams for the ICO exams, because you're challenging yourself. Some colleges like Glasgow will take exemptions because if you pass that exam, you can be exempted from part of the Glasgow exams. And it's good to compare your own standards, and it opens up the road to fellowships. Thank you very much.
Thanks very much. I think we'd better move on.
Yeah,
but
sorry.
there is some information at the front, including about what that very unique foundation assessment. So please come have a look. It's online already. Our next speaker is Alon Barsam for the United Kingdom, who's going to share his experiences about arranging a fellowship in the United States from the United Kingdom. Thanks, Alon.
Thanks very much, Anthony, for asking me to talk here today. What I want to do is personalise my experience of coming from Europe to the US for part of my training, as well as give you some details about what was actually involved. So between July 2010 to July 2011, I did a clinical and surgical fellowship in cornea, cataract and refractive surgery in New York. And as well as giving you a background to what this involved, I'm telling you a little bit about timing, about organisation, about what I perceived to be the benefits and the drawbacks of doing this. And then I will give you some time at the end for questions. How many of you, by the way, are thinking about doing a fellowship in a different country to the one which you're doing your main training in that's here? Okay, well, that's quite a lot. That's great. Good, so relevant talk then. So why did I do it? Well, in the US, residency training is actually quite short and low in volume. So the average US resident will do about 100 phacos over the course of their residency. But to compensate for this, the fellowship training, if you select an appropriate fellowship, is actually very high in volume and quality compared to countries like the UK. So, for example, my current resident in my current place in the UK, she's doing 10 phacos independently just today while I'm away, because I normally do my surgical list on Tuesday. She's in her second year, and by the end of this year, we'll have completed 250 cataracts in 1 year. Having said that, my feeling is some of the UK, quite a lot actually of the UK fellowships, you're kind of left to your own devices, which is fine if you're an experienced surgeon in that subspecialty. But if you're not, it's nice to have someone actually watching over you, which is how it works in the US. So there's very close consultant supervision. So I would say only about 5 or 10% of patients that I saw were not then seen by the consultant who I was working for as a fellow. That's invaluable. If you don't know the subspecialty that you're trying to train in, you have to have close supervision of someone basically explaining what's going on and giving you feedback. And then obviously the opportunity to experience the healthcare in another country to your own is really also invaluable, because there's so many different ways of doing things. So the fellowship I did, I worked for these two men, Hank Perry and Eric Donenfeld. And they're very high-profile cornea and cataract surgeons. So Hank Perry is the associate editor of Cornea, and Eric Donenfeld is the current president of the American Society of Cataract and Refractive Surgeons. In the US, many ophthalmologists are office ophthalmologists, so will not operate or do very low volume. So the kind of tertiary and surgical centres are extremely high volume. So these two men had done a combined total of 7,000 corneal transplants and over 57,000 laser vision correction procedures. And basically took many of the most complex cases on the East Coast. And there genuinely was nowhere in the UK where I felt I could access that kind of experience and training, which is why I chose to go through the rigours of what was involved in going abroad, which I'll tell you about shortly. So I was the only corneal fellow to a practice of 26 ophthalmologists, of which 7 were cornea and refractive consultants. They were not just these two, there was Marguerite MacDonald there as well. I mean, it was a very high-profile practice out on Long Island. 5 million people catchment population, only corneal fellow. Why did I do it at the time of my training? I didn't do it at the very end of my UK training. I did it in my final year, so I counted it towards my kind of residency training. But as residency training in the UK is 7 years, I had fulfilled all of the competencies in the UK, and there was support for me to do this. It was actually associated with my wife, who you see here. She actually is a haematologist and was given a research opportunity at the same time. So, many of you will have girlfriends, boyfriends, spouses, partners, and actually a decision to do training abroad will invariably have to involve them, and that's another kind of complexity of it, basically. My kids were young enough so I could move them around, not so old that we felt it was going to be too unsettling for them. I really can't overestimate this is, by the way, this is my predecessor, the fellow who preceded me, so I knew I had big shoes to step into when I saw his number plate, eyes guy. But the fellowship was years in the planning. It was incredibly time-consuming. It took an enormous amount of motivation, time and work to do. And the reason for that is essentially I had to qualify in 2 countries. So, as I'll tell you in a second, different fellowships in different specialties in different states all have their own requirements. But for this kind of high-volume surgical fellowship in New York, the requirements were such that I was basically I was qualified in the way that a US resident was qualified. So I had to do all of the US exams, as well as fulfill all of the visa requirements. So luckily for me, I had many reasons for marrying my wife, and one of them was not the fact that she was born in the US and allowed me to have a green card, but that was actually a requirement of my fellowship, that either I had done a residency in the US or that I was a US citizen or a green card holder. So as well as all of these exam requirements, which were rigorous enough, I had to get myself a lawyer, immigration lawyer, and fulfill the requirements for obtaining a green card. Meeting with the fellowship directors at international meetings was also important. So all of us have got a limited amount of resources in terms of how much flying abroad you can actually do to contact people. So, at times, I remember there was one time where I flew in for I think it was a Step 2 clinical skills, and did essentially a kind of 6 or 7 hour exam at what would have been 1 or 2 o'clock in the morning for me, because the only slot that was available was the evening slot in Philadelphia. And then travelled the next day to New York to have kind of 5 meetings in New York City with various fellowship directors, because the way it works in the US is that you keep flying to, and you fly within the US to each kind of fellowship interview, but if you're abroad, that's impossible, basically. You can't fly across the Atlantic 5 or 6 times in a 6-week period when you have clinical commitments. So I had to try and use my initiative to combine exams with meeting fellowship directors, and all of my meetings, I kind of avoided the UK meeting scene, so I kind of came back as a UK consultant, and people were like, who are you? Because for 2 or 3 years, I'd been at the ASCRS, the American Academy of Ophthalmology, every single US meeting, because they were opportunities to meet with fellowship directors, because the way it works in the US is you'll be doing a residency somewhere. Your residency director, if you're good and supports you, will call up their friend who is the fellowship director in the subspecialty that you want to do and say, look, I've got a fantastic resident here. He or she is going to be applying for your fellowship next year. Please have a look at their application. Well, no one in the UK will do that, because very few people in the UK know people well in the US, and there's not that same kind of camaraderie, I suppose, so you basically have to do it yourself. I think that would apply for any international fellowship, is that you need to make sure that you try and meet the people who you'll be applying for, so they at least know who you are, so your application form isn't just an anonymous form of someone from a different country. And you have to, how do you choose which fellowship to do? There are a lot of them. The San Francisco match is very helpful, so it has a lot of, you go online, tells you a lot about fellowships. There is an association of US kind of professors that basically accredit surgical fellowships for being for basically fulfilling requirements. So in cornea, they have to basically guarantee you a minimum of 25 corneal transplants within the 1 year in order to fulfill the requirements. And then there's separate requirements if it's going to be also a refractive fellowship and also cataract. But there's nothing as helpful as asking around. You speak to the current fellows, you speak to the previous fellows, and you find out what their experience was. It's very helpful if you can speak to fellows who no longer have an association with that practice. So if you speak to a fellow who was a fellow in a certain university who is then now working in that university, obviously they'll tell you it's a fantastic fellowship, but you want to try and get independent advice from people. And then look at people who have done it in the past. So, my fellowship, 2 pretty high-volume refractive surgeons in the US and Canada had done that fellowship, and then John Kanellopoulos in Greece had also done that fellowship. So it had a pedigree of quality that made me feel comfortable, as well as the fact that people gave me good feedback about what was involved. There are state-specific requirements which vary enormously. The US is such an enormous place, I don't think it's feasible to just say, I'd like to do ocular plastics and I'm going to go to the US to do it. You have to try and hone in a little bit and say, well, I'd be prepared to go to New York, Florida, California. You have to hone in and choose 1 or 2 states. My wife had a research offer in New York, so I was only looking at New York, and it would have been impossible to do what I did looking at more than 1 state because it was so involved. So in New York, to do a surgical fellowship, you do need a full unrestricted license to practice because they need to bill for the work you do. So if I was doing a pterygium excision in the office, for example, my consultants are basically continuing to see patients. The practice still needs to earn money on account of that work, and they can only do it if you have a full unrestricted practice license to practice. Having said that, if you were to do, let's say, a medical retina fellowship where no surgery was involved and could be predominantly observership, you may not need to do any exams, and it is very dependent on what the specialty is you're doing, what the state is of where you're doing it, and what that individual program will have as its requirement. Again, if you do it in a university practice, they may not have such rigorous requirements, but in a kind of private practice setting, then there's obviously a stronger kind of financial consideration to what your qualifications are. And then online searching, look up your people that you're working for. So Donenfeld and Perry, I think, have published about 350 papers between them, all on PubMed, and so I felt that there was going to be an academic element to the fellowship as well, which is something I was interested in. So what are the benefits? I'll tell you the drawbacks as well, but the benefits is that it was an extremely high-volume fellowship, so I did 134 corneal transplants in 1 year. Now, in the UK, that would probably take me 3 or 4 years in some of the best centres. And then this is quite unique, so over 300 femtosecond LASIK, laser vision correction. That's not doable in the UK. No one trains UK trainees in laser vision correction in the UK, and there's lots of complex reasons for that. But in the US, they have a fellow's price for laser vision correction. So for people that can't afford Eric Donenfeld, they were told, well, there's a fellow who's working under the supervision of Eric Donenfeld, and you don't have to pay as much if he's doing the surgery. And in a time of a recession where it's expensive, people were very keen on that, and that's how I was able to get my volume. So there's also innovation. So I became one of the first people in the world to do laser cataract surgery because Eric Donenfeld was very instrumental in bringing the device into the US. And then, again, in the UK, I think nurturing and promotion isn't really part of the training so much. The US do that in a very strong way. If they like you, they'll put you out there. And that's helpful. It's allowed me to successfully establish a tertiary practice in the UK. I now attract referrals from all over the south of England. I've only been a consultant for a year. There are drawbacks. Expense is considerable. So you do get paid as a fellow, but not very much. In the UK, you get paid a little bit more because it's 8 years of training. You've got to be able to support yourself during that time. In the US, it's 3 or 4 years. So you basically take the financial hit knowing that you'll earn the money when you come through. A lot of work, a lot of planning. It can be unsettling for the family. Here you see my 2-year-old, although he wants to be heroic like Superman, he's also dressing and looking a little bit like a gangster. And you have to also combine it with your spouse's career aims or partner's career aims if relevant. So this is my email address. I'm also on Twitter, Facebook and LinkedIn. If any of you are thinking of coming to the UK, perhaps I'm now about to put in an application for a kind of US-style UK fellowship, which will be high volume not only in cornea and refractive but also in cataract. So please get in touch because that will be available to you within a year or 2. Thank you very much. Any questions?
That seemed a lot of hard work. Can I just have a show of hands to see who still wants to do a fellowship abroad?
I didn't say I wanted to go to the US. Would you do it again?
I would. Yeah, absolutely. Yeah, and with no hesitation at all.
Sounds fantastic, but it sounds really unrealistic.
You need to think about it very early in your training. Yeah.
What made you leave the US?
It's interesting, actually, because Hank Perry will be retiring in a year or two, and I was given a contract. See, in the UK, to get a consultant job, loads of hurdles to jump through, interviews and everything. In 3 months before the end, they walked in with a very lucrative contract and said, "Here you are, I want you to stay." You know, as in, the job's yours. To basically take over from Hank Perry in cornea, and within 10 years inherit Eric Donenfeld's laser vision correction practice, the biggest laser vision correction practice on the east coast of the US. So financially, a very tempting offer. But, you know, family considerations. There's a saying, happy wife, happy life. I love ophthalmology. I mean, I've done work in Ghana. You could literally put me anywhere, and I would love it. And there are pros and cons, and basically, for essentially family reasons. All of our family and friends are in the UK, so I came back to do it for that reason.
Thanks, Alon. So now, looking at this from the other perspective, Sanjay Kadar from the US is going to speak to us about fellowship in the United States, tips and what to expect, a US perspective.
Great. So I'll actually try not to overlap too much on Alan's talk. Actually, I thought it was great. But I'm speaking from the perspective of certainly an academic physician in the United States, someone that's fellowship director, and also someone that's directed several ICO fellows, as a matter of fact. So again, I have no financial relationships or interests. Obviously, education is generally not very lucrative. So why do fellowship in the U.S.? Alan already covered this. It can be a very immersive hands-on experience, as he discussed. Many of the fellowships are actually quite high volume to make up for lower volumes in residency or the shortage of residency. In addition, there are multiple fellowships in almost every specialty. So if there is a lack of the ability to do a fellowship in your country, generally the U.S. offers several fellowships to be able to cover that particular subspecialty. And as he pointed out, chance to experience a difference in healthcare delivery. It's certainly a much different system than you would face almost anywhere in Europe. So finding a fellowship, SF Match is very good, although there are several fellowships that are not offered through the match. You can look at that through individual academic institutions. They often offer specific international fellowships that do allow you to do some clinical work. There is I think as was mentioned before, the AUPO Fellowship Compliance Committee has a designation. If you look at a fellowship that has this compliance designation, then you're guaranteed that it falls within certain requirements. There are minimum numbers that they're required to meet and minimum teaching requirements. Networking and I would never underestimate the power of networking or personal contacts. As a fellowship director, I've certainly met people at international meetings and also at the American Academy of Ophthalmology meetings who have inquired about fellowships, and that's then led to either short fellowships or full clinical fellowships over time. So personal contact is sort of how things are done in fellowship in the United States, and it's very important, I think, for you to get out and meet people, as Olan said. Remember that subspecialty societies also have individual meetings within these larger meetings. So if you can make the American Academy of Ophthalmology and you're particularly interested in, say, neuro-ophthalmology or uveitis, oftentimes those societies will have smaller meetings at that time, and it's a good opportunity for you to then attend those, meet people in your particular area of interest. The experience in fellowships can be variable, although, as I just said, several of the fellowships have specific fellowship compliance designation and they have minimum numbers. There are those, beyond the minimum numbers, there can be a great variability in your experience. So the compliance designation is important, but it's very important to ask previous fellows and also perhaps other academic physicians or other attendings that may know what the experience you'll receive in that fellowship is. Funding is also variable. I've had several fellows that have come in our fellowship, which is uveitis and anterior segment surgery, and they've come with their own funding, which obviously always makes it a little bit more, it opens up more opportunities. When I was a fellow, they were only taking one fellow, and someone came with additional funding, and they opened up another spot for that person because there was enough opportunity to train another individual. Some fellowships that are designated as research fellowships at certain institutions also allow up to 20% clinical experience. So don't always discount that. If you're looking for clinical experience, don't discount some of the research fellowships as well. And observerships, or such as the ICO fellowships, can actually be a great way or a great introduction into a lot of these fellowships. You may get a better opportunity to meet and interact with physicians that are running fellowships. And from there, again, that personal connection then may open up doors for you for further clinical fellowships. Once you've found a fellowship that you'd like to apply to, always make sure there's a central application service that you can use to apply to multiple different fellowships, but certain fellowships actually require additional materials or additional paperwork. Specifically, fellowships in neuro-ophthalmology or pathology use individual applications. There are many requirements, as Alon said, and I think it does require a lot of time and patience to get through. Remember that the visas generally required are J1 or H1B. You can be sponsored for a J1 visa by the believe it's Education Council for Foreign Medical Graduates, ECFMG, but some institutions require you to be sponsored by that institution. So always, really, you have to look very carefully at the requirements for each fellowship. Always reach out to the preceptors for the fellowship. It's very important to have that direct contact. And if you do, in fact, there are, I would say I have a difference of opinion to Alon. I do believe that there are many fellowship directors, at least maybe not in private practice, but at least in academic circles, that do have interactions or at international meetings. And so some of your professors may in fact have contacts in the United States. As a fellowship director, I'd say this goes double for US applicants. Always check your spelling and grammar, especially if English is not your first language. Have someone read it over for you. It doesn't inspire a lot of confidence if you get something that has a lot of grammatical errors or a lot of spelling errors. Be specific as to your aims and goals when in your training. So if you would like to train in the United States in cornea and refractive surgery and you want to go back to the UK and be the biggest femtosecond laser surgeon around, definitely say that. A lot of the fellowship directors in the United States are very interested in training people that will then go back to their country and actually establish themselves. It's sort of a feather in our caps as well. Follow up with each individual institution after you've sent in your application. Make sure that the application is complete. Don't assume that it is. It's the easiest way to get burned, so to speak. And very important, be unfailingly polite and kind to secretarial and administrative staff. Oftentimes they have a lot of influence with the fellowship director. So, as Alon said, the application process requires ample reserves of both time and patience, and you really have to plan quite early. Even if you are not accepted, stay in touch, because Americans love persistence, and if you're persistent, it will pay off eventually. A lot of times opportunities will open up. I've certainly, people that were not accepted to our fellowship initially, other opportunities came up and we called people that we did have an interest in and made them some offers as well. So make your own opportunities. So what do you do once you've been accepted? So before you arrive, you have to be prepared for even more paperwork. As Alon alluded to, you have to be on insurance panels in order for the practice or the institution to bill for your work. Academic institutions oftentimes have less of a requirement for this, university positions, because they generally consider you as a graduate student and they won't bill necessarily for your services. Housing arrangements, it's always helpful to discuss with them. In our institution, we have apartments in New York City that are available for our fellows. But not every institution has this, but sometimes they will have arrangements outside at other apartments or other housing arrangements. Reading, especially articles written by your preceptor, it's always helpful to know sort of where they are and what they expect from you. In the US, it's less, we're a little bit less formal, as I'm sure, in most aspects of our lives. And so we have a very dialectic interaction. It's very important that you, if you have questions or you want to challenge the director, I mean, do it politely, but I think most of us are responsive to that. So it's that interaction of having our ideas challenged is part of what keeps us directing fellows and continuing to teach. And so it's very important that we consider you a colleague. In other words, most of for the most part, fellowships are 1 year, possibly 2, and we know that we're going to be interacting with you as a colleague in 12 to 24 months. So it's important that if you are accepted and you are a fellow, that you interact with us on that basis. Know that you're on our level there. Again, it's an immersive hands-on experience. Know what's expected of you. Generally, you're expected to be able to work independently. Surgical proficiency is important. I would say that I think this was mentioned at some of the other talks yesterday, but practice suturing. I don't expect, for our fellowship, I don't expect you to be able to know how to put in a Boston keratoprosthesis or do deep anterior lamellar keratoplasty, but if you can't tie a suture, it's definitely going to, I'll be less confident in your abilities, and it's definitely going to set the tone for the rest of the experience the following 12 to 24 months that you're in the practice. Additionally, you may have resident teaching responsibilities. Again, this applies more for university positions, but you may be called upon to be the first person to act as the consultant, after which you'll then consult with more of the senior physicians. And research also can be a part of that, probably more so in university positions than in private practice. But you may know whether or not it's expected of you to complete a research project or to put papers in. So in summary, I think as a fellowship director, I'm obviously a little bit biased, but I think that fellowships in the US can be very rewarding, especially for international trainees, and they're equally rewarding for us as consultants. And most fellowships are very hands-on, but the application process does require time, patience, and diligence. So I wish all of you a lot of luck if you do decide to go down that route.
So I think we have time for maybe just one question. Okay, no questions. So with that, we'll just move on to Dr. Grace Sun, who's going to talk about volunteerism and volunteering opportunities for YOs. Grace is the Residency Program Director at Weill Cornell Medical College in New York and has spent a significant amount of her time working on international programs overseas.
Good morning. Thank you all for joining us. I'm delighted to be here to share my passion for global health. The purpose of this talk is to discuss, give you an overview of some of the issues in global health around the world, and to discuss how you, as a young ophthalmologist, can get involved. So I'm going to start with my global health story. I'm sure many of you either have or will have a global health story. I started in the Peace Corps in Nicaragua, and that was 2 years of service, basically building latrines, working in the health center with women and children. And that's where I decided to go to medical school. And from then on, I decided to become an ophthalmologist because I was determined to tackle what I saw in my time there as a solvable problem, and that is of blindness. So the motivation for what I do today in global health, working on the initiatives in Tanzania and some other parts of the world, can be summed up in one photo. So this is where I'm from, New York, New York. And what does this photo have to do with global health, or more specifically with global eye care? This is a photo from October 28th, 2012, and Hurricane Sandy touched down on New York. It's the worst storm in decades. And this area, you guys know Soho perhaps, was now dubbed as SOPO, or South of Power. So this is where I live, somewhere here, but this is where I work. So one day I went home from work and I took the bus and I crossed that line. And suddenly I was south of power and it was dark. So except for the lights on the bus, I suddenly became one of those without. No electricity, no running water. Felt like I was in the Peace Corps again in Nicaragua. But in New York City, of all places, people were searching for a place to eat, shower, plug in their cell phones for a connection for the world. So this is what I saw as a metaphor for our work in global health and certainly in global eye care, because these people were literally living in the dark. So I'm going to move on to another map. I like maps. I like to travel. This is also a map of the haves and the have-nots. 90% of blind people live in our developing world. So the areas in the red and the tan are where almost 1% of the population are blind or visually impaired. So how many people does that exactly translate to? About 39 million. And that, I learned, is about half of the population of Germany. What's more is that about 246 million people are visually impaired. Roughly the UK, France, Spain, Italy, and we can't forget Denmark since we're here, combined, 246 million people visually impaired. But why? So you may be surprised. It might not be what you think, but the infectious causes of blindness are decreasing as a result of public health interventions and socioeconomic development. It's actually just cataract and refractive errors, glasses basically, that make up the majority of visual impairment around the world. So here's New York. In the developed world, where we are most of us are from, it's AMD, glaucoma, diabetic retinopathy. And again, south of power, glasses, cataracts. Although still prevalent, the leading causes of vision loss across the world is no longer trachoma, trichiasis, corneal opacities, due to antibiotics and increases in environmental health. It's no longer trachoma. It's no longer something as exotic as river blindness or onchocerciasis. It's no longer malnutrition or vitamin A deficiency, night blindness, keratomalacia. So what are we going to do about it? The leading causes, again, are avoidable. I think you would agree. So this is our challenge, your challenge as well, because about 80% of global blindness is avoidable. And this is a problem of human resources as well as financial resources. So it's not just about money. It's about human capital, human resources. To put it into perspective, in the United States, there's about one ophthalmologist for about 10,000 people. In India, it's about 1 in 100,000. In Africa, it's about 1 in 1 million. And in rural parts of Africa, it's actually about 1 in 10 million. So we certainly need to galvanize the efforts of young ophthalmologists to join in our effort, because this is our challenge as our world becomes smaller. And again, the leading causes of global visual impairment may be addressed through cost-effective measures, high efficiency, high quality care, such as small incision cataract surgery, which you may have learned about, many of you may have even done. So there are numerous studies that show the high quality and high efficiency techniques that work in India, Nepal, for example, and this is one of the solutions that we can tackle for global blindness. So now you've decided that there is a problem, perhaps you want to go. And I would argue before you go, you have to ask yourself a number of questions. Why are you going? Are you going just to do the work, the good work? Are you getting out of your day-to-day routine? Are you just going to travel? Are you going to learn? Or perhaps are you going to teach? Why are you going? And where are you going? Are you going to the rural hills of Nicaragua, or perhaps in the middle of nowhere in Africa, where you may not be able to provide as much care as you'd like because it's a very sparsely populated area and you're going for a week? Would your services and your talents be better served in a larger city in a developing world? In the developing world, excuse me. So before you go, you might want to ask, what does the host country need or want? Does that match with what you're able to provide? What is the impact of your work? Is it developmental? Are you creating systems? Are you educating? Or are you just providing individual service? Is it about personal development? And funding. There's always an issue about funding. And as you know, going across the globe can be quite expensive. What about safety? Maybe exotic to travel to the middle of Africa. However, think about personal safety, vaccinations, perhaps you're bringing your family. Something to consider. Another question is, what are the legal and ethical concerns? Are you even able legally to do surgery in a different country in Africa? What are the ethical concerns? Something to think about. Who's going to take care of those patients that you treat when you're gone? So after you think about those and more and understand what your motivations are and what you can provide, where can you start? So I would argue that in your first few trips, it's best to go with an organization, an established organization. For example, Orbis, C International. Perhaps in these types of meetings, we talked a little bit about networking. Meet some of us who do go abroad, and perhaps we can put you in touch with someone who works in a particular part of the world that you're interested in. At the Academy, I always have to put a plug for our course. There's International Opportunities for Young Ophthalmologists there, and there are networking opportunities where you can talk to global health experts. Again, think about what you'd like to do. Perhaps you have something to offer and can connect with an academic institution abroad and teach. Or perhaps you can collaborate and do some research. So I want to end with a story. And this is a woman that I met in Tanzania. We had worked on a project with the UN, the Millennium Villages. She lives in a very remote village. I could probably not locate it on a map, even though I've been there a few times. She's 72. She lives with her family, and she's blind. She lives with her family who many of the days have to stay home from work or school because she couldn't see. And our team, when we went there, had determined that the root cause of her blindness was something as simple as cataracts. And we operated on her, and we left. But what we did do is a few months later, we went back and did some follow-up. And unfortunately, we couldn't find her. We did follow-up for about 200 patients, and she was nowhere to be found, not in the health center, not in her home. And I feared the worst because many of these patients are elderly, they're frail, and we packed up to go. And as we packed up to go, I heard the truck. And they did find her because she was out in the fields tending to her cattle with her newly restored sight. And that's a moment that we all love to feel. That we made some sort of difference. Remember, previous to that, she stayed at home, a burden to her family, unable to contribute, and now there's something different in her life that was possible. So I love this quote because I think it speaks to us as young ophthalmologists. Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it is the only thing that ever has. So again, I welcome you to visit New York. And I hope you and I can bring light to Lower Manhattan as well as the rest of the world. Thank you.
Right, so for the sake of time, we're just going to move on to the final talk of the session, who's Dr. Brad Feldman. Brad is the chair of our Academy, American Ophthalmology YO International Subcommittee, and also is director of some international projects at the Wills Eye Hospital in Philadelphia.
Thank you, Paul and Anthony. So my talk is going to be about this digital age and learning and practicing and sharing as an ophthalmologist in it. I have no relevant financial disclosures, but as Paul mentioned, I work with the American Academy, not only in an international way, but also with the iWiki, which we'll talk about. And I'm a consultant and attending at the Wills Eye, and we'll talk about some of the resources that the Wills Eye has online. So this is sort of the outline, and I'm going to get moving because there's a lot of things to get through here. Start just talking generally about doing these things in the digital age, and then talk about some specific resources. So typically, the way that many of us have learned throughout our training is like sessions like these. Someone stands up and speaks to you. We, the speakers, control the content and the message being delivered, and you, the listener, passively receive that. Certainly, we all know now that we can hold information in our hands and at our fingertips. This is me using my iPhone and an app. And as seekers of information with information now on the World Wide Web and apps on computers, we can actively find information that we want at the moment we want it, whether it is in the room with the patient, we want to look up a drug on a formulary, or we want to look at the, these are some of the most commonly used apps that I use, on the Wills Eye manual, and check the management of a patient with hyphema. What should I be doing? What should I be thinking? You know, we can do that and find that information right when we need it, which is a switch from how things were years ago. Also, typically, the way that we learn in a clinical setting, whether it's in the operating room or at the slit lamp, to get a skill is through skills transferred directly from a mentor to the mentee. And that's certainly a very powerful way and the most common way that we learn. But now a lot of us can learn things by just looking at videos online. And there are certainly surgeries that I've performed now over the last few years that nobody taught me. I just went online, saw a technique, said, I think I could do that. And certainly you can. And there's so many resources now that allow you to do this, and it's a very powerful tool. The way that we share information, discuss, debate, decide what is a good intervention, discuss ethics. This has often been face-to-face communication at meetings like this, expert panels, or talking to fellow physicians. And the way that we communicate as physicians is changing as well. A lot of it's happening now at your keyboard, at your home, or in front of a computer, doing Skype or video conferencing. There's listservs for subspecialty communities. The Academy has an online community, Facebook. And now they're very powerful tools. I'm a cornea specialist, and for cornea, I can go on CareNet, which is a listserv, which has thousands of other cornea specialists on it, and I have a patient who's particularly challenging. I can type up a little email describing the patient, maybe upload a video or an image, and say, hey, does anyone ever seen this? Can you help me? And instantly, I have thousands of specialists there to help me. In addition to the tools that are available to us as physicians, our patients now have unlimited amounts of information, for better or worse. And a lot of that information is to judge whether they should be seeing you or going to your institution. And certainly any patient that has a choice to who they can see is going to try to make that an informed choice. And some of these, some in the U.S., these are some of the websites that folks go to. And they also, when they come to see you, before they see you, they may say, well, I think I'm having an acephalic migraine. I'm seeing these geometric patterns. And you certainly have patients coming in specifically describing terms that they never would have come up with on their own. And some of them are probably using, I think the two most common sites would be Wikipedia for getting information. And then if you tell a patient, well, you're going to have a pterygium surgery, and they go on YouTube and watch what that looks like, some of them decide they don't want it anymore. A lot of patients also watch TV. We have a popular show in the U.S. called The Doctors, and there's a lot of television that tells patients about different diseases. It's not always coming from the experts themselves, from ophthalmologists, maybe other doctors describing ophthalmology. And when things are reported, we as ophthalmologists don't really have control over the content. There's a photo from me here. I was interviewed, and although I thought I got my message across in this interview, when they go back and edit things, it can make you sound like you're saying something you're not. So even television and journalism it's not us controlling the content. On the other side of the screen there on the left side, there are some resources where we as ophthalmologists really do control the content. One of the best ones really for patients is iSmart, which the American Academy produces. And it's produced at a level that patients can understand about very common diseases, cataract, age-related macular degeneration, all the common eye diseases, really brought to the patient in a way that they can understand, but it's all created by ophthalmologists. And for patients who want some more information, the iWiki, which I'll speak about in a moment, is at a higher level of information. And then kind of the ophthalmology equivalent of YouTube would be the iTube, where the ophthalmologists are putting the content on, and it's vetted in some way. As patients have more choice, we as physicians then are kind of forced or willing to do more marketing of our own, and our institutions do that as well. We now have a lot of money put into creating slick websites for our institutions and buying into some of these things like Top Doctors and the ratings websites. And you can even pay money and have your institution come up higher on Google searches. You can have your reputation controlled, make sure that no bad reviews come up of you online. And the more we buy into this, the more money those things will make. Switching gears here a little bit, instead of competing with one another, there can be websites that offer a lot of collaboration and a lot of good between ophthalmologists. And I just wanted to speak a little bit about one site called Opening Eyes that relates back to Grace's talk. And Opening Eyes is a website that was created by Jessica Fieldmeyer out of Nebraska that tries to increase collaboration between ophthalmologists working around the world. This is the website for openingeyes.org. And basically you can go onto the site, register, click on the country that you either work in or like to work in, and then you can say what you're doing, what type of work you do, if you work with any non-governmental organizations, and if you're doing that work, when you're going to do that work, so that people who want to volunteer, folks who want to work in your country with you or offer their assistance can then collaborate better. We don't have a whole lot of time to go through a lot of the resources, but we will go through a few here. These are some of the most, I think, high-yield resources that are absolutely free. The first one I'm very much involved with, which is the iWiki. And the iWiki is a Wikipedia-type site. It's an encyclopedia of everything ophthalmology, but all the content is created, edited, and reviewed by ophthalmologists only. Any of you who are an ophthalmologist can go on and register to contribute and create articles or edit the articles that are existing. Right now, it's about 3 years old, and we already have over 300 articles. We get 85,000 hits each month. The articles look like wiki format. You can add videos or multimedia. There's an article here that is on smartphoneography. I just wanted to show this article in particular because this is a great way, if you guys have smartphones, and a lot of you do, it's quite easy to take pictures at the slit lamp or even videos and to share it with one another. So check out that article. If you want to contribute to the iWiki, just go to the iWiki.aao.org, and you can just click on the Getting Started, and simply follow the instructions. Just send an email saying that you are an ophthalmologist, and within 24 hours we can get you up and running on the site. Another website, which is purely video, is put out by my institution, the Wills Eye Knowledge Portal. At Wills Eye, we do a lot of education. We have 24 residents each year, 24 residents at the institution, and we have a lot of educational lectures. So what this site does is it collects all the lectures that are given in our grand rounds, visiting professor rounds, and also a lot of the surgeries that are performed at the institute, and puts it all on an easily navigatable portal online. So you can go and you can watch George Spaeth giving a lecture on glaucoma. You can watch Carol Shields talk about juxtapapillary choroidal melanomas, or you can watch Mitch Feynman or some of our retina specialists actually performing the retinal surgeries and taking you through them step by step. So invaluable resource, absolutely free. You just need to register, and you can actually get CME credit on that as well. Another site that's been around for a while, but I think is very good, especially for young ophthalmologists, is iRounds.org, which is out of the University of Iowa. And this has a lot of functionality to it. You can go and do ophthalmology tutorials, which are broken up into subsections. Here's an example on just how to communicate to a patient during cataract surgery, a great thing to think about as a young ophthalmologist. You want to avoid that oops in the OR, and this takes you through what you should and shouldn't say. There's a lot of links here. One of them is to Atlas of Gonioscopy. There's a video Atlas of Gonioscopy, which is a great way to learn what you're looking at. And then probably the most popular thing on iRounds is Thomas Oding has a cataract surgery for greenhorns, which takes you through all the steps of cataract surgery, complications, and really gives tons of clinical pearls and videos as well about what you should and should not to be doing during cataract surgery. You may have also be familiar with his Facebook page, which links back and forth to the cataract surgery for greenhorn site, in which he posts surgeries from his residents from that week and some trouble that they may have gotten into and how he got them out of it. Membership has its benefits, though. Certainly I don't know what to say in Denmark. In the US, we'd say the Cadillac, and in the UK, I guess it'd be the Rolls-Royce. But here, we'll say the cream of the crop site is really the ophthalmic network and the one network, the ophthalmic news and education network of the Academy, which has pretty much everything you can imagine. You might recognize this guy. Has lots of the most current news in ophthalmology. It takes you through tons of educational resources, from videos to courses. Here I will just highlight a few things. There's the Academy Grand Rounds, which is a great way to explore different case presentations. There are different courses online that are very complete. This is one on DSEC versus PK. One of the most popular things of it is its full access to 7 of the most important journals in ophthalmology. And one of the newer features here I wanted to show is the masterclass videos. This is where some of the master surgeons in their fields, here's David Chang talking about cataract surgery, will take you through some complex cases and give you some really good advice on how to deal with them. But really, we could spend an entire hour looking at this website. And unfortunately, we don't have that time. I want to say that coming soon will be an iWiki page on ophthalmic digital resources, and one of you, I hope, will write it with me. So if you would, whoever wants to do that, please go on to the site and register and contact me, and I would love to write a page with you, and we can then offer this to everybody. So thank you.
Great. So that's our final talk. If there's no other questions, most of our speakers are still here. I think we had a wonderful session. Thank you to all our speakers. Went from, European certification to education, volunteerism, digital resources, fellowships. So I think we covered the gamut for young ophthalmologists, and I appreciate everyone here who stayed in attendance. We're only 5 minutes behind schedule, which is fantastic. And I thank you all for attending.
Sorry, I didn't handle my...
No, it's good. It was a good session.